To thank Laerdal Medical Canada for sponsoring the event today. Their investment in continuous professional development for the nursing community is very much appreciated. Today is actually our first official advancement event since COVID-19 began. So we're really happy to have all of you joining us today and to see you all here, even if it is virtually. We are really pleased that we actually reached our registration capacity for the event today. So it just goes to show how valuable this community is and how much we still value connecting with each other. We have other virtual events planned for the fall, including 2 more Laerdal Lunch and Learns, so please stay tuned for more information about those events. Before I introduce our speaker today, I just wanted to cover a few housekeeping items. Firstly, you may have noticed that we are automatically muting everyone as you join the meeting. Since there are so many of us on the call today, we do thank you in advance for keeping your microphone muted throughout the session. We do welcome your questions, however, so please feel free to use the chat button at the bottom of your screen to type in your questions, and Helen will address as many of them as she can at the end of the presentation. Secondly, I do want to let you know that we are recording the session today, so we can share it with those who were not able to join us. We'll also email you a link to the session, as well as a survey after the call, so you can provide us some feedback on today's event. Now it is my pleasure to introduce today's speaker, Helen Edwards. Helen is the Chief Informatics Officer at Sick Kids Hospital, where she has worked in a variety of positions since 1981, including bedside nursing, education, project management, and director. She has led initiatives focusing on identifying, evaluating, procuring, implementing, and optimizing large-scale informatics and clinical technology solutions. Helen is also an adjunct lecturer at Bloomberg Nursing in the Master of Nursing program, as well as in the Master of Health Informatics program. In 2018, she received an Ontario Nursing Informatics Group Award of Excellence, and she is a board director on the Canadian Nursing Informatics Association. Thank you so much for joining us today, Helen. Over to you.
Thank you so much, Laura, and what a pleasure to be speaking to you all today. Let me just, there we go, get the technology working. Laura, can you confirm that you can see the slides?
I can see them, they look great.
Perfect, thank you. Well, what a pleasure, as I said, to be here today. I looked through the list of registrants and was really pleased actually to see the range of graduation dates. And although I do know that that does not necessarily mean anything, because as a 2003 master's graduate, I certainly was not a spring chicken. So I do recognize that we also have a range of ages that are attending today and a number of names that I recognize. And so I'm flattered to see that you joined this chat. I'm going to be going actually more breadth-wise than depth-wise, because I want to hit a number of things. If there are some topics that you want to ask more questions about, certainly, enter that into the chat and we can see we can get to after. And I'm always available by email as well, and happy to connect with anyone. That's one of the pleasures of my role. All right, and now, there we go. So what are we going to do today? A bit of an agenda. We're just going to get grounded in what nursing informatics is. Thought I'd talk a little bit about what CNIOs do, and then go through some past, present, and future. So where are we going? Where have we been? What are we doing now? Where are we going? So nursing informatics, there's some quite general agreement on what it is. The Canadian Nursing Informatics Association and Canadian Nursing Association in 2017 put out a joint statement identifying what nursing informatics is, and it really speaks to the science and practice that integrates nursing information and knowledge. And it very much also speaks to the range of activities within that. Collection, extraction, aggregation, analysis, interpretation. It really is all about data. People like to focus on computers when they hear informatics. Computers are a tool. It isn't really the only thing involved in informatics. So I always like to get that point across. I also love this. This is not new. It goes back to Bickford and Hunter in 2006, but it really is about moving data into information and then into knowledge, and eventually even into wisdom. And I didn't include it in the picture, but it's certainly something that I have heard and like to speak to as well. what does an informatics, CNIO do? So, there's not a lot of us across the country. In fact, unless someone can correct me, I believe there's only 5 CNIOs across the country. Now, there are directors of nursing and clinical informatics, often in nursing roles as well, of course, but it's only about 5 CNIOs. I'm not sure that we all have exactly the same job description, but there certainly are some commonalities. And if I'm going to, on a very practical basis, identify what the 4 buckets that we would all share would be, it is really influencing the technology transformation and adoption. There's always something new coming along. There's always something we need to be planning for moving forward. Really close collaboration with nursing leadership in the organization. I work incredibly closely with Mary McAllister and Judy Van Cleef, our CNE and our Associate Chief of Nursing Practice in the organization, because it really is about supporting the practice administration and research efforts. I also work very closely with the clinical operational leads in the organization. I talk about predicting, but I do put that in quotes there because it's less about predicting and more about anticipating for the future, looking and sitting at strategic planning tables to see how technology and informatics can support the strategic plans moving forward. And it really is also about collaborating with all the disciplines. Nurses work most closely with all other disciplines in the organization for the care of the patient. And unless we ensure that those workflows cross appropriately across the interprofessional practices and care that we provide, we're really missing something. So I think those are 4 buckets. There are more, but those are the top ones I was wanting to put out today. So let's look a little bit at our past. So Florence Nightingale, our wonderful Florence, she is really considered by many of us as the, I should get rid of that, there we go. Now I'll get that out of the way, as a really early informatics nurse. And in her writings, she very much spoke to her inability to get the data that she needed to make the kind of changes that she wanted to make. So, I mean, we're going back, quite a while, hundreds of years, and she really was ahead of her time in wanting to use information to improve nursing care. I love this, and I may be a bit hard to see. I got these from the archives at SickKids, and you'll notice there it says October 12th, 95. That's not 1995, that's 1895. And I just loved this because you could see the, well, you could barely see actually. I mean, reading that writing is a bit challenging. So it's really, I found this interesting to look at these. This one here, this next one here, where it's talking about a milk diet and a regular diet and everything that people write in. And it looks like someone's coffee got spilt on that. Maybe betadine actually that was wiped away. And then someone's vital signs. So they were doing informatics back there. Their tools were very different, and that was probably much harder to look for trends. But in fact, nurses have been doing informatics for a long time. In the 50s and 60s, so practices were growing, care was becoming more complex, nursing resources were becoming more available to be used. Nursing stations were, although that there had traditionally been, were really considered the hub and where communication and information exchanges occurred. In the 50s and 60s, computers were still rare that nurses would actually touch, and they were typically in the background of hospitals and other healthcare organizations. And it was really in 68 that the French term informatique, really referring to the computer milieu or the environment, was coined, but wasn't used very much at that time, particularly not in Canada where we were a bit behind. I love these pictures and these uniforms, a little bit of a throwback. Then in the 70s and 80s, nurses began to recognize that computers actually could help their practices and their processes, particularly when it came to documenting, evaluating care, doing assessments, and any kind of automatic functions that could be included that would take the manual work away from the nursing staff. When personal computers improved and their computing power went from, giant mainframes to more desktops and more affordable, it became more user-friendly, and organizations were more enticed to use computer systems to support the care that nurses provided as well. At the time, though, in the 70s and 80s, it was still not the kind of computer systems we see today, which are more integrated. At that time, particularly that early, it really was about, a best in breed kind of system. So you'd buy a system for your emergency department, another system for your operating room, another one for, inpatient and whatever. So there really was limited integration, and those that were done really required technical interfaces rather than a system doing everything at the same time. It became, nursing informatics, in fact, became a recognized specialty in the US. It wasn't in Canada yet, although it is now in some, but not all provinces. And then some of the job titles came out. I'm sure there were some that were still called computer nurse. We had some of those up to the early 2000s at Sick Kids, but the States are a little bit ahead. They probably had informatics nurse, nurse informatician, and maybe the odd computer nurse here and there. Nursing-specific software became more obviously evident that it needed to be, again, documenting signs, but also looking back at the information in order to plan care not only for individual patients, but starting to do more for patient populations. When we get into the 90s, we really are talking about, that's when the computer revolution really came into being, and that computers became much more affordable, easier to access, and something that it was harder to say why you wouldn't get one than why you would get one, because people were using computers in their everyday life and certainly in business, and so the need to use computers in healthcare, including nursing, became incredibly obvious. The internet, of course, became an incredibly valuable tool with all kinds of access to resources and applications. Wireless started to make an appearance, and making it much easier to provide care to the patient where they were and still access the information and communicate with colleagues as well. So now getting a little into our present, what are we doing now? So I'm asked all the time, well, what do nurses want from technology? We're all the same. We want our work technologies to make things as convenient for us as they do in our personal lives. And we know a lot of us, I don't think there's probably a lot of us on here today that don't have a cell phone, if not more than one, some laptop or something at home, access to online resources, maybe do your, certainly shopping now, I think a lot of us probably do online, banking, all kinds of things. So when we're at work, do we want anything different? Not likely. So what do nurses want? They want things the same as others do: bigger, better, faster, stronger, access to all the information we need in a size that helps us. But sometimes that actually means that smaller is better and faster and stronger because it enables us to be mobile. And that's the next thing on the list. Mobility is key. What do we want as nurses? We want access to the clinical systems that house the patient information. And that could be vital signs, orders, resources, anything. The drug references at your fingertips. We even, it's not widely used yet, but at Sick Kids, the iPhones that the nurses carry on the wards, they can even do the barcode, the drug scanning with the camera on the iPhone. So it's really trying to limit the number of devices as appropriate to do more things. Communication is everyone uses cell phones for communication, but also for alarms and alerts from monitors, identifying something is due, could even be nurse call systems that are integrated. Again, some of what we need to think about here is just because you can do all these things and send all these things to a phone, should you? Not necessarily, because every time something goes to that phone, the nurse is interrupted, and there's lots of research these days on the risks of that constant interruption, risk to the nurse attention, risk to patient safety. So really making good, balanced decisions about the kinds of things that go to phones. And then, of course, all the clinical apps that are out there, calculators, disease-specific aids, treatment plans, all kinds of things that would be there. And who doesn't want an app for something? There are lots of apps, hundreds and thousands of apps out there. So some to support mental health, where patients can identify how they're feeling at that time, and then get the help that they need. ultrasound app to attach to a phone. So talk about mobility. Probably not going to have super duper diagnostic properties, but it's sure going to let someone in an emergency department or out in the field know whether something is critical or not critical at the time. Good cameras, so attachments to the phone, they can take a really good picture of a skin lesion, a wound, whatever, and send it on and have it go straight to the patient's record that can be viewed by anyone who needs to see it. Blood pressure and pulses has been around for a little while actually, but very handy. Patients can actually record their own, and it can either be transmitted remotely through technology, or if the area is not up to that or the person, then they can even manually jot it down. But this is used quite widely. The world's smallest microscope. Probably out in rural areas or out in the field or in developing nations, this can be incredibly helpful. The world's tiniest petri dish, which I think is the cutest thing, and again, using technology to be able to bring diagnostics into the field. And then, of course, everyone has some kind of a fitness or a health aid where they can keep track of their own sleep and vital signs and fitness plan and diet and everything. Some are connected to their health providers' own records that they can see, and some are still independent. The other current thing that we're seeing a lot of, and it's certainly in Ontario, but certainly as well across the country, is that most organizations are wanting to move to an integrated health information system. So Cerner, Meditech, Epic. Epic is something we introduced at SickKids a couple of years ago. And when I talk about integrated, it means that every area of the organization, in fact, is using the exact same system to collect information on the patients, and then it's documented once, seen everywhere, and that all the clinicians and support staff that need access to it have access to it, and then that you collect allergies once, you collect demographics once. It makes it safer and much more efficient. If your hospital is implementing something, get involved. Nurses are so key to be part of the implementation teams, part of the project teams, because who knows more about the patient flows, about the workflows of others, about how patients actually move through the organizations and how different disciplines come in to see them. Nursing has this down pat, so being involved in these discussions and the plans where the workflow is so important to be considered, couldn't do without nurses there. Data. If this is the one thing you take away from you today, take this away. Data is incredibly important for us to move forward, and nursing data is being more and more recognized for its importance. Currently in Canada, there's a National Nursing Data Standards Initiative, and it's been going on since about 2016 with these symposiums. And the strategy is really to represent, teach, capture, and report on nursing practice, and the importance that nursing practice has to patient outcomes. What's really clear is that if we don't standardize our nursing documentation, how do we standardize care, and how do we actually benchmark against each other to say what is in fact the best thing for safe care, for improving outcomes, to be more cost effective? So the standardized data is something that is still being developed across Canada. Many of you, particularly those of you who work in adult organizations, know about HOBIC, Canadian Health Outcomes for Better Information and Care, which started its journey, I'm going to say around 2007. And it really is about standardized questions for admission and discharge assessments. It's real-time data. It can be used for that. It is used for those individuals that are in and out of hospital, but it is also used for broader, for more populations as well, so that care pathways can be changed to really help decrease discharge times, improve discharge experiences, and really set patients up for doing better when they leave hospital. So I could not talk about the present without talking about COVID-19. So to say that it brought challenges would be an understatement, but boy, did it ever bring a number of new opportunities as well. It's shocking to think that now, just over 6 months ago, there were things that we would say, oh, we couldn't possibly do that, there's too many barriers, that suddenly with COVID, those barriers seem to go away. So at SickKids, we have Epic as our integrated system, and we've had to date, so in the last 6 months, about 300 or so changes that needed to be made to Epic to accommodate um, COVID. So basically, lab testing, doing the travel history and any kind of screening of patients and families, collecting data, and the reporting of the data and reporting of results and everything. So as I say, about 300 changes that need to be made, or new features added into Epic, and it's been incredibly helpful. What we actually said, so as I say, we've been live with Epic for just over 2 years now. Prior to that, we were in a best-in-breed environment with some but not every system integrated, and the number of times we've said we don't know how we would have managed everything we need to do with COVID without an integrated system. So we are pleased that we were as far as we were. We also had to, as an organization, so I sit within the Information and Management Technology Department with a cross matrix to clinical, of course. And we, in IMT, we really had to ensure that we set staff up to work from home who could work from home and still be able to do everything that they could do if they were in the hospital. That might be the corporate staff, but it certainly was a lot of clinical staff as well who needed to work from home, and how they needed access to records, needed access to patient records, but also needed access to their patients. So this is where telemedicine and virtual visits became incredibly important. We had such a rise. So we were about 1% of our clinic visits were actually done virtually through telemedicine at the hospital. We had a 600% increase in the first month, and that continued to climb. Now that we actually have opened the doors a bit more, it's dropped off a bit, but we do imagine that, in fact, our numbers will start to go up again in fall. Our future. So one thing here, so many of the things that I talk about in our future here are not just our future. We're doing them currently, but we may not be fully there. We are still working out many of the things that we have to continue to expand on and continue to invest in and continue to learn more about. So patient empowerment has become not that it's never been important, but become more possible in the past few years, and certainly more on that. So if we think about patient portals, and at SickKids we use the MyChart, but not the provincial MyChart. MyChart is also what Epic calls their patient portal. And a lot of hospitals and organizations now have portals that patients and a proxy perhaps can get access to information, so results, diagnostic imaging reports, the ability to book their own appointment, all those things. Patients who and their families that participate more in their own care are more likely to be successful in achieving their health goals, and it's a fact. And the staff and the patients who actually have access to something like a patient portal are really able to do that. A few weeks ago, actually no, more than 6 months ago, because it was pre-COVID, I was in the elevator, and a teenage girl, probably about 14 or 15, was on her phone, and she was just busting. She's showing her mom, look at this. I can see my medications. I can see that note from the last visit when I was here a couple of months ago. I can update this thing here. And she was literally busting because she was so excited about what she could see. And I asked her if I actually could be able to share that with the MyChart team that's in my portfolio. And when I told them, they were delighted to hear how personally how much was impacting even just one person, because if one person thought it was good, others probably think it's great as well. So patient portals we talked about, and it's about the security of access. We do know that there are times that clinicians may email patients and families directly. It's not necessarily considered secure access, because anything that they put in there of personal health information and you're sending it to a Yahoo account is not considered incredibly secure, whereas portals and the secure messaging in there being encrypted is much more secure. That self-appointment and self-registration certainly puts the power in the patients and families' hands, certainly can result in fewer no-shows. Telehealth or telemedicine opportunities, in addition to the remote visits. And certainly we've had discussion at SickKids about should offering a virtual visit become the rule rather than the exception. I'm not sure we're there today, but I think that in the future, because of the success that many organizations are having, that may become turned around a little bit, that only bring patients in if they need to have hands-on, if there's something, or procedural obviously, but something that cannot be accomplished by a remote visit. We always say remote visits should be at least as good as an in-person visit, and that's when you know you're successful. More enhancing remote monitoring can, and there's such a range in that. It can be as simple as phoning in, you know, your weight, a specific vital sign, your blood sugar, but it can be as advanced at almost a hospital room at home with the right supports from home care. And everything automatically on, you know, walls of monitors in a hospital that can appropriately decrease a patient's stay in hospital and have them safely cared for at home. And I think that's where that balance is. When is it appropriate for us to have patients at home with that amount of technology when it doesn't become not just a patient risk, but a burden on the family, where they stop acting as the parents or the loved ones in the case of adults, rather than the family. So it's all about balance. So artificial intelligence, we hear a lot about artificial intelligence, and it can go from little things to the crazy things we see in movies and TVs that I think a lot of us hope will never come true. So what artificial intelligence can do is really assist with that collecting, organizing, storing, analyzing huge volumes of personal data, of population data, and can help with that evidence-based decision making. So we hear a lot about data-driven decision making, evidence-based decision making. It pulls it all together. AI relies on huge amounts of data to be able to look for those themes, those threads, and be able to really then use their algorithms to learn and then to identify whether it's treatment options or diagnostics. We hear a lot about the use of artificial intelligence in radiology and its ability, because of the amount of data that's available, to say, okay, you know, that kind of lung lesion, we've seen, you know, 1 million records of it. We've put it together with all these different, or the system has put it together with all these different articles and everything. They can identify, you know, within a tiny, tiny fraction of error, what in fact that tumor is, and what in fact the appropriate treatment would be for a person of that age in that kind of a, with those kinds of socio-demographics, and really spit out a whole treatment plan for them. It's actually being done now. So chatbots are actually, they're real-time by computer communication, and it's for, you know, non-urgent but important kinds of things. And the chatbot, it could be a patient requesting some information. It could be getting some advice on what to do for their ingestion that they've had. It could be a number of things. And in some areas, they're also able to, through the person that's on one end, the patient, we'll say on one end, by putting in some information, able even to, before that bot or that avatar, they choose an avatar that actually is gender and ethnically relevant for the person who's on the other end and wanting the information or needing the assistance. So predictive analytics, we hear a lot about that already. Again, really looking at large amounts of data for those trends, the patterns, the you know, predicting the diagnosis and the treatment options, and that's a lot of what's behind what people, the primary thing people think about when we think about AI right now. And robotics. So this is one of those things that, you know, it could be a real slippery slope. So this is a very cute looking robot. Japan has invested a lot of time and energy in looking at robots, including in healthcare. What we hear a lot about is robots taking over some of the personal care, where can be some time saving for nursing, can be some efficiency, can also decrease some of the wear and tear on nurses and others' backs, you know, from lifting, things like that. Again, about balance and in ensuring that they're introduced appropriately. There are opportunities now to even looking at how robots can be integrated with the health information system and electronic health record, that when specific orders are entered, it goes to the robot, and the robot could then go and get the required supplies, say, you know, for a dressing change, for an IV bag to be set up, and the tubings that are there. So there are, if we look at it from a personal care or an assisting the nurse perspective, I think some of us find that a bit more palatable. Lots of growth still to come in this area. Virtual reality, we also hear a lot about this. It can help healthcare providers, healthcare practitioners, really learning, if you think about surgical techniques, the kind of experience that you can get through the virtual reality, you know, that close proximity to the patient. Many people can be taught at the same time how to do a specific procedure that may not have a critical mass in one particular area. Really being immersed in assisting with procedure, so great learning from that perspective. And also that real life kind of simulation through an emergency to be better prepared when if the real thing hits. For patients, it's equally as important. It can bring the patients home to them when they are an inpatient, and they can feel like they're in their house or whatever their happy place might be. It can help to teach patients, and it can help the care provider on in the hospital help the patient better understand how to use their own kitchen, for example, to make healthier food choices, to prepare themselves when they're going home, that they can kind of share that experience together. In fact, there's talk about that, you know, we have pharmacies now where you get an order for a medication. There can be a pharmacy, in quotes, that you can get an order for a virtual reality kind of experience that can then be dispensed to help people move forward with as part of their treatment, as an adjunct to treatment, to prep them for discharge. The Internet of Things is it's basically the terminology given to really connecting, that interconnection of computing devices that are really embedded in our day-to-day kind of technologies, in our day-to-day kind of activities. So when patients are connected, we can provide additional devices to them and really look at that real-time monitoring. And again, it's about getting more patient data. So there's things like we hear about the smart home, so smart bed, where a pad that is clearly, you know, has computer components in it, can give an indication of how is the patient sleeping. Do they move a lot when they sleep? What's their breathing pattern, vital signs, everything like that. Look at this. I think this looks awesome. It almost looks like you're putting on a dressing, but in fact, it can do a range of assessments on the patient, including some specific vital signs, some blood results, a number of things that can be gathered from there. Sort of this shows how that interconnectedness can go from the patient wearing, this looks like an oxygen saturation probe that can go to their own fancy watch that can be then sent through a phone to someone's computer, to their healthcare provider, that without having to do anything other than wear the device, someone is getting information about their health and then can actually provide treatment as required. And then even smart clothes that someone would wear, that all of those things are measured at the same time. I'm not sure I'm personally ready for that yet, but it certainly is something that's being investigated and is possible right now. I want to talk a bit about the role of nurses in informatics. I said earlier, nurses do informatics every day. Anytime we collect information, look at it, pull it together, analyze it for an individual patient or a group of patients, and then interpret it and use that, we are doing informatics. Informatics supports nurses in whatever role they are in. If you're a practicing nurse, if you're in administration, if you're a nurse involved in research or in academics, we use informatics every single day, and it supports nurses every single day. Lots of ways for nurses at every single level to get involved. Call out what is not working in charting system. This is a small, very practical example, and it sounds like it's very granular. It is incredibly important. Nurses spend a lot of their day documenting. Some of the information I pulled out of EPIC just, I don't know, 3 or 4 months ago or so, showed that on average in the hospital and sick kids, a nurse spends about 140 minutes in a shift in EPIC. That is looking up results on all her patients, documenting in the flow sheets, communicating with others, but 140 minutes out of a 12-hour shift on average per nurse in that hospital. So anytime we can call out what's not working and take some of those minutes away from being in the system, puts those minutes back in dealing directly with patients, and that's not a trivial thing. When there are new systems or new features that are being introduced, get involved as subject matter experts. You have a voice, use your voice. No one knows better than a nurse what nursing cares about and how it impacts their patients. Don't forget to use the data when you're looking at making recommendations to change practices, because that data can sometimes be right in the system that you're charting in. And then you may adjust resource allocations, you can change practices. Remember to use the data. If you don't know who to ask, your manager, your director likely does know who to ask. And sometimes patients have something, often patients have something to tell us what to say. And often as nurses, we're the ones that remember that the voice of the patient needs to be heard. Never hesitate to ask a working group if they thought to include a patient in the development and the discussion, whatever. I rarely have anyone say no to me when I ask if we should look for a patient, a parent volunteer to be involved. Just to show from, this is our Sick Kids 2020 to 2025 strategic plan that was introduced just a little while ago. And everything that I have a red box around shows, and there's probably even more than that, the importance of data or informatics or anything to support a strategic plan. So if you're involved in that in your organization, remember, data, informatics, everything to help move your organization forward, to help to also determine what are my priorities, and my role are to support the priorities of the organization and the strategic direction that we're all working on together. So that was a whirlwind tour through our past, present, and future, and I am happy to take any questions that you might have.
Thank you so much, Helen. That was really great. So we do have a couple of questions. The first one, someone is asking if you could make some recommendations for courses or certificates that people could take up to learn more about this and get more involved in nursing informatics.
Yeah, do you know, and perhaps if people want to email me directly, I can help with that. So there are a number of programs across the country, and in Toronto, in fact, we're very lucky. There are short courses. So something, if someone is looking for something to do more immediately, there's something called a WINI, a Weekend Immersion in Nursing Informatics. And it's typically like a Friday afternoon, a Saturday, and a Sunday morning. I attended it a very long time ago, of course, in person, but now I'm quite sure that they offer it virtually, and it really gives a great background on what informatics is, and actually gets into some computer technology. It may not have the same kind of methodology right now. They may actually do it you can do it on your own time, maybe it's all taped, but look into that Weekend Immersion in Nursing Informatics. There are also certificate courses that are offered. Again, many of them could be online. George Brown College happens to have one that is, they call it a post-diploma program that's actually quite good. They typically have a placement to it, and then you can choose the place you want to do the placement. Then, of course, there's lots of master's programs. There are some online, like at University of Victoria. But for those of you who may be looking at going back and doing a master's, I've had many U of T Master of Nursing students do a practicum with me focused on informatics. And in fact, they've actually ended up in informatics roles afterwards. You can be creative with how you do your electives and your placements in a Master's of Nursing. There's also the Masters of Health Informatics at U of T. MAC has a Masters of eHealth, and these are some really good practical courses and programs as well. If you want more information, I think we can share my email at the end, Laura, and then I'm happy to chat with people directly as well.
Yes, absolutely. We'll share your contact at your email address for sure. Someone else in the chat has just suggested that the University of Calgary has a postgraduate certificate as
Yeah,
well.
yeah, yeah.
Okay, wonderful. So a question related to the AI section of your presentation, which I think is becoming more and more relevant, and people have more and more questions about how that's going to affect the future. Do you see a possibility of a computer triage system? And if so, would there be room for nursing intuition in such a system?
Wow, what a good and scary question. So yes, I absolutely do see that triage can become more algorithmic. So it requires the person giving the history to actually provide the appropriate information. It's how, so where would the nursing intuition come in? How much data would there actually need to be on nursing intuition, which I fully believe in, to actually make that part of an algorithm? Will it occur in my lifetime? Not so sure, but some of you youngins on there, you may see it in your lifetime. Or does it become a second phase where the triage system through AI, through all of that, spits out a specific amount of stuff, and then the nurse can look at it and say, wow, this, front of the line sort of thing, or, applying that kind of, gut or sixth sense to it that can be really challenging to um, to articulate.
Great. Okay, and then we have a third question, and I just want to welcome everyone to please put in more questions into the chat if you have any. We have another question of someone who's looking for some more details and information on job prospects in informatics, like different opportunities that you've seen. If you could just share a little bit about that.
Sure, sure. If you live in Southern Ontario now, wow, the options are opening up. I don't think it's any secret that the Central East cluster has 7 hospitals going live with Epic. Hamilton Health Science has just announced their entire corporation is going live with Epic. It's coincidentally Epic, but maybe not so coincidentally. And that is a number of hospitals. They have all their postings up right now. UHN is making a decision about which vendor they are going with, and that is apparently over the next couple of months going to be announced, so there are opportunities there. What I say to people is that, sometimes it's not a direct line to an informatics role, but that it's really doing a bit of a sidestep first. I've had a lot of staff at Sick Kids, a lot of nursing, and other staff at Sick Kids chat to me and say, what can I do? So this is what I recommend people do. Get a good foundation in nursing. I rarely would hire anyone onto into an informatics nurse role with less than 5 years nursing experience. I think to be able to really have a gut and say, well, this is what that workflow looks like, or this is what practice would really do. Not that we represent practice, but we don't separate ourselves from it when we're an informatics nurse, really takes about that 5-year mark. Some people maybe a little less, others a little more. So get that gut for nursing that you can speak to it. Get some credibility, and how you get credibility is getting involved in things. They may be in the area that you work. It may be going to your chief nursing executive, or going to the director in your area and say, I really want to get involved in something where I can, where I can participate, where I can be heard, where I can be profiled, and really get seen. That's a way to gain credibility, but it's also a way to get outside of your little zone and see how decisions are made in your organization, how they use data to make decisions, all of that. So get a little out of your comfort zone. And don't be worried about making a lateral move. And I think the last thing I've said to people, and I know it's hard coming from me, who's been at Sick Kids for pushing 40 years, to say, if it means leaving your organization, leave your organization, because sometimes that's the best thing. It doesn't mean you can't go back if it's an organization you love, but sometimes opportunities come up that you have to, step way out of your comfort zone and leave. But if people want to talk to me separately on that, I do a lot of counseling about that in education. I'm thrilled to chat with people about it.
That's wonderful. Thank you so much. Oh, we just got another question. Do you have any specific peer-reviewed journal or book recommendations in this area of nursing or health informatics that you could recommend?
Yeah, so I'm kind of sad to say that there are no great Canadian nursing journals focused on nursing informatics, but the nursing, oh my gosh, Helen, nursing leadership often has some that Laerdal is the editor on. It often has some great informatics focused articles in there. There are certainly some American journals, but being on the board of the Canadian Nursing Informatics Association, we're refreshing our strategic plan, refreshing our website and everything. I would encourage anyone who has an interest, you don't have to be in a role, but an interest to join in Ontario. The Ontario Nursing Informatics Group is a wonderful resource and a great opportunity to network with some lovely people who are involved in informatics and have great sessions, and then the Canadian Nursing Informatics Association as well. If you join ONIG, you get a cut on the CINIA rate as well. Yeah. Little plug for everyone there.
That's great. This is great information. Does anyone else have any questions? Please feel free to type them into the chat. Helen, you're being so generous with your advice and your information. I think it's really, really great. Oh, here we go. We talked about the various technologies. Do you ever discuss, well, you did touch on this a bit, but could you talk a little bit more about security on patient data?
Yes, yeah. Do you know, that's a really good question. There's rarely a new initiative or a new feature that we're discussing that we don't actually have our Chief Information Security Officer, CISO, sitting at the table as well, because of the risk for patient information to getting out there. And anytime, you know, again, it's that kind of double-edged sword. We want to make sure that the patient information is available even outside the hospital. An example, COVID. So we happen to be a hospital out of the many, in the province that are doing COVID tests that are not just our own patients. So we are doing it for other organizations that don't have a lab that can accommodate it, so we do that. So we have to share the results back to the OLIS, Ontario Lab Information System, but we also, of course, have patient information. So how do we do that? How do we do the right thing to share the information in a timely manner, but make sure that the information that we have about that patient, because of course we do, we have their name, some demographic information, their OHIP number, etc. How do we make sure that all of that information is not shared inadvertently? The same is true. So most hospitals that have some kind of a system, Epic, Cerner, or otherwise, want to make available information there to community providers who have referred the patients in for whatever that specialty care may be. So how do you do that? And at the same time, make sure that they get what they need. Is it too much? Do we rely on professional accountability? Do we put some, barriers or things in the system that prevent people from getting too much? So it's always a discussion, and it's always about ensuring that we meet the mandate for protecting personal health information, but also ensuring that we make the information available in a timely manner so the patient can get the care that they need.
That's great. Thank you so much. Some more questions flying in here. I'm just going to take a look. Let's see here. I'm sorry, there's a lot. I'm just going to read them quickly here. I'll just read this one to you. So with all the data provided to patients, do you find some difficulty in patients being able to understand these values? And are they provided so that a non-healthcare professional can understand what they're looking at? I think you mentioned in the elevator when you were with a patient and they had access to all the information in the app. Mm-hmm. So I think they're talking sort of about for the back and forth for that. Like if someone has access to their results, how is that accounted for in making sure the results are understandable by a non-healthcare professional?
Yeah, really good question. And I'll tell you, before we went live with the patient portal, MyChart, that was one of the biggest things. The technology is not the issue with patient portals. It's having staff in the organization understand the benefits and their role in marketing it, and having patients and families understand the value of the tool. So I think the first thing we have to get over is that it's not our information, it's their information. And if they want access to it, whether they fully understand it or not, it's their right. We currently have a delay, so it's 5 days for lab results, 5 business days for lab results, and 7 days for DI reports. And that is intended to give the healthcare provider ability to review the results, and if there's anything that they feel that they need to discuss with the family, a new diagnosis, a recurring diagnosis, they have an opportunity to do that. I'm sorry about my phone. Hopefully my husband will get it. They have an opportunity to chat with them ahead of time. But there's also a movement to actually having those results available real time, no delay. We've not gone there yet, but it certainly is something that's being discussed all across everyone that has a patient portal. And the other thing is, typically families have enough of a relationship with their healthcare provider that they understand that when they look at the results, that they'll, if they haven't been contacted and something's abnormal, that they will be contacted, that they actually understand. If we think about our oncology population, they know, many of them, their blood results. They know exactly what they mean. They know exactly what to expect from a phone call, whatever. So I think that we need to be less paternalistic and more understanding of how the families, the patients are involved in their care. There's a movement in the States called Open Notes, and we've just adopted that over the last few months at SickKids, and in fact means if it's a patient information, make it available to them. And in fact, we're following that initiative right now and making more and more notes available to patients and families.
Okay, great, thank you. This is kind of a big question for near the end of the presentation, but I think it's a good one.
Ready.
What are your greatest concerns regarding the future of healthcare informatics, and how would you suggest that we deal and manage with these concerns?
I don't have concerns. I have excitement. I think it's all about opportunities. I think that nurses have been making such incredible contributions in nursing informatics over the years that there's no doubt and there's no question that we should be at the table. I think with the growing number of nurses in informatics leadership roles and project management roles, that we also have, we're known for being able to take that forward. I think the speed of change is, let's embrace it. Let's not be scared by it, but let's be planful about it. Let's always consider that the patient is at the end of everything that we do, and if it's better for them, it's better for us. But let's, as nurses, make sure that we understand the tools coming our way and have a voice in how they can be implemented, and perhaps some of the features, and prioritizing the features. So it's not fear, it's, as I say, it's excitement and eagerness to be involved in some of it, and then pass that baton on, hopefully to some of you out there to carry forward doing that. So not about fear, about opportunity.
I think that's a great way to look at it. Okay, I think we have time for one more question. So this is specific to your role. So someone is asking about, do you utilize elements of project management or Lean Sigma principles in your role? Could you talk
Every
a bit
day.
about that?
Yeah,
Okay.
every single day. Now, I happen to be, so after I was an educator in the ICU for a number of years, I was a project manager for 2 different projects for a while. And I tell you, and I took some project management courses. I'm not a PMP, but I took some courses and took some of the Lean Six Sigma classes. And how it really helps is that when you're in informatics, you're never looking at just technology. I'm a huge believer in the people process technology methodology and looking at things that way. So what project management and Lean Six Sigma or any kind of process improvement helped me do is really look at, how do we ensure that we have some efficiency? How do we ensure that we're not just saying, well, this is the technology, we want to configure it this way, but it actually makes it 5 more steps. So the process is stinky. How do we ensure that we really look at people, process, and technology all together?
Okay, wonderful. Well, thank you so much, everyone. I think there were a couple questions I didn't get to, a couple specific questions, so I would encourage you to reach out to Helen after this presentation. So I just wanted to thank you, Helen, so much for this informative presentation. We really appreciate you taking the time to do this today, to share all of this knowledge with your fellow alumni. It's been really great.
It's been my
And then
pleasure. Yeah.
I also wanted to quickly again thank Laerdal Medical Canada for sponsoring this Lunch and Learn. Our next event will be on October 20th, so stay tuned for more information about that. And I'd also like to thank Shauna Spicer and the Bloomberg Nursing IT team behind the scenes for helping us organize this today, and all of you for attending and joining in this really enriching conversation. Thank you so much, everyone, and enjoy the rest of your day.